Now, introducing our speaker for this session, Courtney Wood, Medical Science Liaison for Fresenius Kabi.
Thank you, Jessica, and good morning to everybody. I'm very excited to see the room's pretty good for the last day. Sometimes I know everybody has to leave early and stuff a lot of the time, so it's good to see everybody. Like Jessica said, I am Courtney Wood. I'm a board-certified nutrition support pharmacist, and I'm currently a medical science liaison with Fresenius Kabi. So our objectives today, we're going to talk about essential fatty acids and what are the requirements, how are they metabolized, how do we evaluate the lab results that we get. They are different. It's different than evaluating your electrolyte panels or your CBC. And then we'll go over some case reports about that really will kind of tie all that in of how do we actually look at these labs on a case-by-case basis and decide, does our patient have essential fatty acid deficiency or not? So kind of the rationale for this is intravenous fish oil, treats pediatric intestinal failure. We have a lot of these new lipids that have come out that contain all these ingredients that we didn't have before. It was always, for many, many years, 100% soybean oil, and so now all of these options have come out for both children and adults, and so it's really important to be able to interpret these fatty acid panels with these new lipid emulsions that differ from what we've had for years before. So if everybody remembers chemistry, I'm sure you all love this slide. I'm not going to go over the whole thing, but it's kind of just to give a background of where do we get the nomenclature for our fatty acids. You can see some of the examples of ARA, ALA, LA, and kind of what they look like. When we look at kind of the number, the C is the number of carbons, the D is the number of double bonds, and then your omega is, or omega minus, is the position of the closest double bond relative to the terminal methyl group. So when we look at these, we have our omega-3s and our omega-6s and omega-9s. Those are your biggest families for these essential fatty acids. And so you can see it's all relative to where that double bond is to, what it is, if it's a 20 carbon chain versus an 18 carbon chain, as you can see in the diagram. So this is probably one of actually my favorite slides. When you look at the essential fatty acid pathways, you can see each column is a parent group. So you have your omega-3 fatty acids, your omega-6, and then your omega-9. Omega-9 are considered non-essential because our body can make those on its own, whereas omega-3 and omega-6 we have to intake and get from our food, or if you have a patient on parenteral nutrition, they get it from their fat source. So when we start on the omega-3 fatty acid pathway, that is the parent essential fatty acid is alpha-linolenic acid, or ALA. And then what happens is you have these enzymes that desaturate and elongate down the chain to get to your longer essential fatty acids, or conditional essential fatty acids. So in the omega-3 pathway, it's EPA and DHA. You can see on the omega-6, its parent is linoleic acid, which is LA, and then that elongates to arachidonic acid. Omega-9, that does also go through desaturation and elongation down to meat acid. But what I think is funny is we always think of enzymes as like, oh, enzymes break something down. But in these pathways, the enzymes are actually elongating everything. So it's not breaking down into smaller parts. These are getting longer and longer as they go down the pathway. And what these enzymes do is they work preferentially on omega-3 first, then omega-6, and then they'll move to omega-9. So what happens is when you don't have enough omega-6 in the diet, whether orally, enterally, parenterally, those enzymes don't have anything to work on. So then they start to go down that omega-9 path. And so what happens is that's where you get your tetrine, your trine-tetrine ratio. Your meat acid, which is omega-9, is your triene, and then arachidonic acid is your tetraene, which is your omega-6. So you'll notice that this doesn't take into account anywhere the TT ratio when we start talking about it, omega-3. This is solely looking at omega-6 and omega-9. So what will happen is you don't have enough omega-6 in your diet. These enzymes start working on omega-9, so your meat acid goes up, your ARA goes down, so then you see that triene to tetraene ratio start to go up. And that's what we talk about when we're looking traditionally at EFAD. A lot of times people just look at the TT ratio, but we will talk about in this presentation why that is not the most accurate way to really truly diagnose biochemical EFAD. So why are LA and ALA essential? Like I said before, they can't be synthesized by the body. We need to intake them from our diet, however we're getting them from fatty acids. We don't have the desaturase enzyme to add those double bonds before the 9th carbon methyl end, so we get it from our food. And they're primarily used in 3 metabolic pathways. Obviously, the elongation of free fatty acids, which we saw on the previous slide, energy conversion, and then they get incorporated into the cell membrane, and that affects that membrane fluidity within the body. So this slide kind of talks about the evolution of ILEs. The dates on the top line are outside of the US, and then the bottom will be US approval. So when we really look at US approval of lipid products, we got in the US 100% soybean oil in 1975. That was all we had for a very, very long time. You can see that the olive oil-based ILE was approved in 2013, but didn't actually come to market until a few years later. The 4-oil lipid emulsion was approved in 2016 for adults, and then approved for pediatrics last year in March. And then 100% fish oil. It was used as compassionate use for years before it was actually approved for pediatric use for the treatment of PNAC, and that was in 2018. So I think what this slide really illustrates is the US was kind of behind the times. It took us a while to catch up to the rest of the world with our lipid options. So as these new lipid products have now come to market, we're really trying to learn how does it change what our patients' fatty acid profiles look like. So when you look at the essential fatty acid content of the oils that are actually in ILEs, you can see obviously soybean oil is the highest for LA and ALA. They're omega-6 and they've got some omega-3. It's high in omega-6, so of course they're gonna have the most and their sum's gonna be the most. Olive oil does have some. MCT, by definition, is a medium chain fatty acid, so of course it's not gonna have any long chain PUFAs. And fish oil doesn't really have any of these either because it's it's fish oil, so it's gonna have those downstream products of EPA and DHA. So this kind of goes over the composition of ILEs that are available in the US. And what I think is interesting is you look at the LA and ALA content. Like the previous slide showed, of course, your 100% soybean oil product is gonna have the most LA and ALA, with fish oil being, 100% fish oil being the least. And then you've got your 4-oil emulsion and your olive oil-based lipid emulsion that kind of fall in the middle there between them. But the downstream products of your omega-3 pathway, the 4-oil and then 100% fish oil, obviously those are the ones that have that because they have fish oil in them. The other products do not. And, I don't know why that box is kind of off. But arachidonic acid, you can see both the 4-oil and the 100% fish oil do have ARA also. I do like to note that you'll notice that the 100% fish oil does have some LA and ALA, and the thought behind that is possibly because fish eat plants, and so it's in the fish oil from the plants that they're eating, not that it's actually part of the fish itself. So in the beginning, back in the 1920s, it was really realized that lipids in oral diet were necessary. They had to be in there, and they found that out when they introduced lipid-free diets to animals to induce this deficiency, so EFAD, essential fatty acid deficiency. The symptoms were really attributed to the lack of LA, but subsequently after that, it was determined that ALA is also essential. It's not just LA. Clinical symptoms, usually with LA deficiency, that's where you'll see the skin manifestations, poor growth, but with ALA deficiency, you'll start to see visual and neurologic abnormalities. Sometimes in kids that are deficient for a long time, you can see learning disabilities. So it's not really a benign, just, oh, your skin's dry syndrome. You can really see pretty severe adverse effects if it goes on for too long and you don't reverse it. So when we look at the history of EFAD, kind of the research that was done, again, it started in the 1920s. They fed rats fat-free chow, and of course found decreased growth, dermatitis, all of that stuff, and it actually led to eventual death, and it was determined it was due to a lack of LA. Then Hansen and Holman in the 50s and 60s actually looked at children that were fed low and non-fat milk formulas, and they were noted again. We saw the same things, poor weight gain, all these skin symptoms, and they actually had some infections and all of that. In 1960, Holman, which we'll talk a lot about him, moving on, he actually fed rats a fat-free diet, and that's where he established that a TT ratio of less than 0.4 indicates sufficient fat intake. So that was our initial kind of TT ratio, was okay, if it's less than 4 or less than 0.4, you're getting enough fat in your diet. But then some of these other studies went on as we got further. Holman did much more work that we'll discuss as we move on, that they started really looking more at these fat-free HPN and then fat-free in both adults and pediatrics. And they noticed, especially in 1977, O'Neill noticed that when they added 100% soybean oil, all of these symptoms resolved. And I think what's interesting, because I don't know if anybody else has had patients that can't tolerate ILE, but a lot of times if they can't at all for either allergic reasons or many other reasons, they'll use topical oils like safflower oil to try to alleviate some of these symptoms. But it has been noticed in studies that topical oils will resolve the skin manifestations, but they don't actually correct abnormal FA lab panels. So a lot of that obviously is attributed to absorption. It's very spotty, depending on how much you apply, all of that. So these are some of the risk factors for EFAD. Of course, the ones I think we're going to see the most in our patients that are on PN are the GI diseases. A lot of small bowel resections or short bowel syndrome, EC fistulas. Bariatric surgery has become a huge kind of disease state or procedure that has led to malabsorption now. We're seeing a lot more of those patients, especially in home infusion. So the characteristics of EFAD, so when you're looking at the etiology, it's when less than 1 to 2% of total calories are provided by the essential fatty acids. Pediatrics is a little bit higher, which makes sense because they have more growth requirements. If you have patients with severe fat malabsorption syndromes, and then obviously increased requirements for growth. So when we talk about biochemical EFAD, that's when we're looking at the labs. So that's when you have your triene to tetraene ratio, or TT ratio, is greater than 0.2, which is referred to as the Holman index. That is considered biochemical EFAD. And what that, as I discussed earlier, what that ratio is the meat acid to ARA. So your meat acid starts to go up, your ARA goes down, and we start to see that TT ratio increase. And I think it's important to note that for adults and older children, 7 to 10 days is roughly how long it will take to see biochemical EFAD if they're not getting enough essential fatty acids in their diet. But with infants and young children, it can happen in a few days. They don't have the reserves that adults and older children have, so it's really important to not, especially in our PN-fed patients, to not hold lipids indefinitely. They have to have some sort of fat source, especially these younger patients. Now, clinical symptoms usually start to manifest when the TT ratio is greater than 0.4, and that's kind of what I've already talked about. A lot of skin manifestations, especially with LA deficiency, impaired growth. One thing I think is important with clinical symptoms to note is that clinical symptoms of EFAD can also cause liver dysfunction. So I think sometimes we get in this idea of looking at these labs and we're like, oh, their liver function, their LFTs are high. It's the lipid, we gotta go down. But it could be, if you're already minimizing their dose, that they're not getting enough. And that could be a sign that they actually have EFAD. So, with decreased EFA provision, the enzymes necessary for desaturation and elongation of those essential fatty acids, like I said, they get diverted to the non-essential omega-9 pathway, which increases mead production and then decreases production of ARA. And so, originally Holman thought that the TT ratio of 0.4 was okay, the upper limit of normal, but later it's been found that that is more for the actual clinical symptoms, where now we know that biochemical EFAD is actually TT ratio greater than 0.2. So here's where Holman did some more research, and where he kind of came up with that was in 1979, and looking at the actual threshold for diagnosis. And so he looked to define the normal serum levels of fatty acids as a comparison for suspected EFAD. So he obtained all these samples, he did, fatty acid analysis, and basically none of the patients that he looked at had a TT ratio of greater than 0.4. The average for both the men and women in the study was 0.2. So that's where he got his, what he is now considered the upper limit of normal, is the 0.2. It's referred to as the Holman index. It really is the gold standard used to diagnose biochemical EFAD at this point. And it's important because I think once we start looking at these actual lab reports, you'll see that the reference ranges are very different than what the Holman index suggests. And then this just is some more studies that were done in the 80s. Barr did some studies looking at what's the minimum you need of actual lipid if you're giving a patient PN to prevent EFAD. And so that's where the basis for the 100 grams of 100% soybean oil ILE weekly came from, was from this Barr study. What's important to note is that that is 100 grams of 100% soybean oil ILE. The minimum dose to prevent EFAD of your alternative lipids that are not 100% soybean oil is different. And so it's really important to contact the manufacturers, look at guidance from professional organizations, because that will not translate the same way. And then Holman did some more work, and that's where he established that the ALA requirement is 0.54% of total calories. So this was in a child, so those higher requirements that children have kind of came from this Holman study, and kind of makes sense. Like I said, they have more growth requirements, so they're gonna need more than an adult would need. So since Holman's work in the late 70s, there have been age-specific reference ranges that have come, that have been published for TT ratios. And so they were provided in various populations, and they used different methodology of how they were gonna measure these fatty acid profiles and look for these reference ranges. And they're all significantly less than the TT threshold for EFAD that is the Holman index. So, Segal and Kishtrier and Lagerstadt, they all kind of did things differently, and so we'll see different reference ranges. And it's really important that we remember these are reference ranges, not thresholds for diagnosis of EFAD. And we'll discuss that more when we start to really look at these lab panels from the labs that actually process these tests. So when we're interpreting the TT ratio, it's important to look at what was the methodology, how did they do the measurement. what was the population that was studied for these reference ranges? Because they represent the population that was actually studied. And that they may not represent the actual threshold to diagnose any type of deficiency. These reference ranges usually reflect the norms of the population, what type of fatty acid intake they're getting, whether it's PO, EN, PN. It really does reflect the idea that we are what we eat. So whatever type of fat you're intaking, that's what your fatty acid profile is going to look like. Here in the United States, we eat a Western diet, very high in omega-6. So it would make sense that our TT ratios are going to be very low. But you look at other areas of the world that eat maybe more fish. Their TT ratio reference ranges for the norms of their population are going to look very different than what they look like here for us. And this slide just kind of goes over briefly how you can measure the fatty acid. So whether it's plasma total lipids, plasma phospholipids, erythrocytes. The erythrocytes is really considered to be a better long-term marker of dietary fatty acid intake. This is mostly, especially how I've seen fatty acid panels done. You know, they draw their blood, they take it to the lab, and it gets done. So it really does, it's considered a better long-term marker. So Aspen in 2020 did put out an ILE safety recommendation paper, and they recommend that the Holman index, or TT ratio, of greater than 0.2 is the biochemical indicator of EFAD and really should be used. However, confusion persists. The labs in the US, there's only 2 that currently analyze fatty acid profiles, Mayo Clinic in Rochester, and then ARUP, which is in Salt Lake City. They use reference ranges, which again, as discussed, are reflective of the norms, not diagnosis of EFAD, and their reference ranges differ. They're not the same, which causes a lot of confusion if you get a fatty acid panel on a patient and maybe that time it went to Mayo, but then the next time it goes to ARUP, and then you're looking at different reference ranges. It can be very confusing. So this is an example of what Mayo Clinic's lab reference ranges are for the TT ratio. They do have it based on age, but you can see how low those reference ranges are. And then they have a note that says, you know, an increased TT ratio is consistent with essential fatty acid deficiency. Is that based on those reference ranges? Those are way lower than the Holman index. But when you think about it, these are normal patients on a normal diet in Minnesota. Their TT ratios are going to be low. They're going to be eating a fairly decent omega-6 diet. So really, that statement, is it really accurate to say that if you have a patient that is an adult and their TT ratio is 0.05, that's EFAD? Probably not. And then here's what ARUP looks like in Salt Lake City. So you can see their TT ratio reference ranges are different than what Mayo Clinic's were. So again, it leads to that confusion of, what does all this mean? Like, what do we actually look for? There are some recommendations for EFA requirements. Aspen has recommendations, as you can see on the slide, for term infants and children and adults. They don't really have any recommendations for preterm infants. ESPGHAN, which is the one of the European societies, they do have recommendations for preterm, term, and children, but not adults. So again, lends kind of to that confusion, but we kind of go, at least with the term infants, children, and adults, we go with the Aspen recommendations for minimum needs to prevent EFAD. For your preterm infants, it would be best to contact the manufacturer of whatever lipid product you're using to see what their recommendations are, if they have any dosing for lower end to prevent EFAD. So we have Aspen clinical guidelines for adults of how do we dose our ILEs. For 100% soybean oil, it's going to be roughly 1 gram per kilo per day. Again, the minimum dose of 100% soybean oil is 100 grams once a week. That will prevent EFAD. It's It's important to remember that minimum dosing, we don't just use lipids to prevent EFAD. They're a very good source of calories and energy. They allow you to lower your dextrose load. You don't have to use insulin as much. So we don't want to get into this idea of, oh, we should just dose the minimum. A lot of times that's for shortage reasons. We need to always remember in any shortage of product, we go back to normal prescribing once the shortage resolves. We don't want to live in a shortage situation all the time. For alternative ILEs that are not 100% soybean oil, it's really important to refer to the manufacturer prescribing information, and it really is recommended for daily dosing of these alternative ILEs. And dosing to prevent EFAD really needs to be calculated based on energy requirements for these, and again, the manufacturer can provide recommendations as what's needed for minimum dosing to prevent EFAD. For all ILEs, no matter what they are, you don't want to dose in adults greater than 2.5 grams per kilo per day, and the infusion rate shouldn't exceed 0.11 grams per kilo per hour. It's recommended to hold or limit the ILE dose if their triglycerides are greater than 400, but it's important to recognize that PN without ILE for greater than 2 weeks in adults is not advised. Like the previous slides earlier said, EFAD can develop in adults in 7 to 10 days. So if you're withholding lipids for longer than that, their risk for EFAD significantly increases. So it's really important to just not indefinitely hold lipids. And this is that Aspen recommendation, safety recommendations for adult patients. It's a really great one-pager. You can go to the Aspen website. You don't have to be a member to get it. I love it as a reference. I think it's super nice to just have a one page to kind of guide you in what you're doing. And here you can see where they have their recommendations of, they do give some for minimum dosing for all of the ILEs that are approved in the US. So for pediatric dosing, this is Aspen's recommendations for all the ILE products. They do give recommendations for the olive oil-based product. It isn't at this point approved in the United States for pediatric use, but Aspen does provide some dosing on that. And here you can see, though, they just say monitor EFA profiles if the patient is malnourished, when there's signs and symptoms, and then if they're minimizing lipids for some reason. So not a great it's good to know you should monitor them, but when? And really how often then? Do I just do it once? Do I have to repeat it throughout every 3 months? How do I do it? And then when looking at EFAD in pediatric patients that were on an alternative lipid, this study was used to gain pediatric approval in the United States, but you can see that there was no EFAD seen in these patients. This was short-term PN. They were on for 28 days, but it does show that they didn't see any EFAD using the Holman index for TT ratio to diagnose actual EFAD. So now we're going to talk about some case reports so we can look at real things and say, well, what does it really look like? Like, what am I going to see? So when we look at this study, fatty acid levels were looked at in patients that had EFAD. And I think it's really important to note that in these patients, all three were present. They had an increased meat acid, they had decreased LA and ALA, and they had an increased TT ratio. It's not just one number. Can't just look at the TT ratio and go, oh, it's EFAD, or oh, it's not. It's really important to look at all of these numbers and see how they relate. Are they all present? Is the meat high? Is the LA and ALA low? Is the TT high? And it's important to assess trends. We really want to look at what's going on over time, not just right that second. Changes in just the numerator, so whether it, the meat acid, or changes in just the denominator, nothing else, that most likely reflects either dietary changes if they're eating, or changes in the ILE composition. So if you're changing and going from 100% soybean oil to an alternative lipid, when you look at your fatty acid panels, if anything changes, it's most likely just going to be the numerator or just the denominator. For EFAD, you really need to see trends in both. You need to see that numerator go up and that denominator go down for it to be true EFAD and not just changes in composition or dietary, intake. So it's important to look for that pattern. If we see these patterns, that's when we start to worry about EFAD. So here's an example of what a report would look like from ARUP. Kind of busy. This one I always find hard to kind of read and look at when it's in this circle thing. But I think if you note at the bottom for their results, the TT ratio was 0.1. So we're below the Holman index, even though they listed as high because it's outside of their reference ranges. But when you really look at that example report, the meat acid was greater than the reference range. The TT ratio was greater than their reference range, but lower than the Holman index. But their LA and ALA are normal, DHA was normal, and EPA was normal. So does this patient have EFAD? No, they don't. Yeah, their meat acid's a little high, but that's just the numerator. Their TT ratio is below the Holman index, and their LA and ALA are normal. So you really wouldn't call that EFAD, especially if they're not having any symptoms. And when we look at, what oil source might result in an elevated meat acid? Well, if you have olive oil in your lipid emulsion, that's omega-9. So you're probably going to see higher mead levels in the patients that are on lipids that have olive oil in them. And what might this patient be receiving? Could be, I would say, probably either the 4-oil emulsion or the olive oil based. With the EPA and DHA where they are, I lean more towards the 4-oil. And, what dose and schedule was this patient receiving? We don't know. That wasn't reported when we received this report for this case study. But the lab's interpretation said that it is, these findings are associated with nutritional deficiency of essential fatty acids. Again, do we agree with that? Probably not. So this was a case series that looked at adult obese patients that were on an olive oil-based ILE, and they had prolonged PN intestinal failure, and they transitioned. All these patients transitioned from 100% soybean oil to an olive oil-based ILE, and that ILE provided greater than 3% of the total calories from the LA component. So 2/3 of the patients had mildly elevated meat acid, which makes sense, it's olive oil based. Obviously increased oleic acid, which is omega-9, the parent. But their ALA was within normal limits. The LA was decreased in 2/3 of the patients. Mayo Lab's interpretation was indicative of EFAD. They had no signs and symptoms. And in the study, the author's interpretation of this was that these fatty acid changes were consistent with the ILE they received. So they went from 100% soybean oil to an olive oil based. So you're looking at these are consistent with changing the composition. And the authors state that these changes are going to be seen more commonly in the future, because this study was done in 2019, with the greater use of non-soy-based emulsions. So as we start to use more of these alternative lipid emulsions, we're going to start to see these kind of lipid panels. So it's important to understand what they look like and how to actually interpret them. So with this patient, this is a case study, and really it's like, does this adult have EFAD? So a 52-year-old female, short bowel, you can see what her PN, her daily PN was. She was getting, at the time, only 44 grams of a 4-oil lipid emulsion. That was increased to 50 grams per day, secondary to decreased LA levels. And then they did a follow-up fatty acid profile, and LA and ARA were decreased, and that was identified as EFAD by the authors of this case study. So they decided to change the regimen to the 4-oil just 4 days a week, and doing 100% soybean oil 3 times a week, just to increase the LA. So they're number chasing. They're looking for one number that they want to go up. And they report that improvements in the fatty acid profile were seen as the individual fatty acids moved to within normal ranges. There was a lot of data that wasn't provided in this case study. As you can see on the slide, they didn't describe if the patient had any clinical signs and symptoms of EFAD. And then, interestingly enough, the mead acid levels were not reported, which is really important. Like, we need that to really determine if this patient has EFAD. So when you look at their labs, you can see the first labs that were drawn when they were only on 44 grams of lipid a day. And you can see that the TT ratio was high. It was 0.37, so definitely above the Holman index. Even without seeing the mead acid, we would say, oh, they need more lipid. So they increase it, and the TT ratio goes to normal. It's 0.05. They've got high EPA and DHA, those downstream products that are essential also. Their LA is still low, ARA is still a little low, but their ALA is normal now. So really, is this still EFAD? I lean to no, but without the mead acid levels, it's really hard to truly know what this is, because we need to have all of those. We need to look at all three of those numbers to really determine what is going on. So then they change the regimen again, and you can see everything goes to normal. Now they're happy. But was it really necessary? Is it necessary for them to be on 2 lipids? Maybe, maybe not. I lean towards no, but again, without those mead acid levels, it's really hard to know what I'm actually looking at. So we've talked a lot about what is not EFAD. So what would it look like? So in this case study, they had a 97-year-old female. She was 47 kilos, had a history of dysphagia, had been on HPN for 35 months at home PN, and her PN was only dextrose and amino acids. They had held the ILE due to liver dysfunction and line infections, another fun thing we talk about with lipids. But what's interesting is they didn't really say in the case study how long the lipids had been held for at that point, but they decided to draw a fatty acid profile. So nobody should be shocked that the patient's LA was low, ALA was low, mead's high, TT ratio is high. They're not getting any fat. So of course, they're gonna be deficient. So the prescribers decided that they were gonna add a 4-oil lipid emulsion, but only 20 grams and only once a week, which calculates out to about 0.6 grams per kilo per day, which is way lower than what you should be dosed, especially for an alternative ILE. It's even lower than what you would give for 100% soybean oil. So only 3% of the calories were coming from the actual fat. So they did a follow-up fatty acid profile. The LA became normal, which honestly is kind of surprising. They saw some improvement, or ALA became normal. They saw some improvement in LA and some improvement in mead acid and some improvement in the TT ratio. It's important to note the patient was asymptomatic, which again, I find kind of shocking that not being on lipid at all, that they would not be starting to manifest some sort of physical symptoms. One thing that didn't get reported, or some things that didn't get reported in this case study that are important, they didn't report ARA, DHA, or EPA levels, which is, I think those are important to look at too, to kind of see your downstream products from your omega-3, you know, what are those looking like too? They didn't report those. So when we look at these labs, when they were on no ILE, obviously, totally EFAD. Like you can see everything we talked about is either low or high the way it should be if we're truly gonna diagnose EFAD. But when then they increased the SMOF to 20 grams per week, even though the TT ratio is normalized, I would say they're still deficient, and with that low of a dose, they need to increase that. So is the dose and schedule of this alternative lipid appropriate? Absolutely not. That is not appropriate probably for any patient. It's not appropriate for 100% soybean oil. So this patient definitely needs more lipid. Does the patient still have EFAD after the addition of the ILE? I say yes. I think that, even though technically the TT ratio isn't 0.2, it's 0.17. That's high enough, especially in the presence of a high meat acid and a low LA. I would still call that EFAD, and the dose needs to be increased, which is what my recommendation would be. Need to look at dosing the alternative lipid daily at the appropriate dose for the patient. So this case report, we'll kind of switch to pediatrics for a little bit, looks at an infant on a 4-oil lipid emulsion that was minimized and developed EFAD. So with this patient, you can see kind of on this graph, they were on 100% soybean oil. They started to have their D-billy increase, so they minimized the lipid and decreased the dose to 1 gram per kilo per day. But their D-billy continued to increase, so they decided to switch to an alternative ILEA 4-oil lipid emulsion. But when they switched, they kept the 100% soybean oil dosing of 1 gram per kilo per day, which in pediatrics is way too low of a dose for an alternative lipid like this. So you can see, even when they switched, their D-billies were still rising, and then their TT ratios started to go up. So then when they started noticing that, they increased the dose to appropriate dosing for the patient, which is 2 to 3 grams per kilo per day. So when that happens, you can see, we start to see that TT ratio starts to go down because now they're getting enough fatty acids, but also their D-billy starts to improve. And that's because, like I discussed earlier, essential fatty acid deficiency can affect your liver enzymes also. It can affect your liver. So while we think it's just EFAD, we think it's the lipid all the time, in this case, it was that the dose was not appropriate. And so once they started appropriately dosing, their D-billy resolved also. So that's where it really goes back to the importance of dosing correctly for the type of lipid that you're giving. And whether it's 100% soybean oil, an alternative lipid, making sure that those doses are appropriate and at least the minimum needed is really important. So this study looked at a long-term pediatric patient, or long-term pediatric HPN patients or home PN patients, and they looked at the RBC fatty acid profiles in 25 patients. You can see the inclusion criteria here. They were on a 4-oil lipid emulsion, anywhere from 5 to 7 days a week, averaged about 2 grams per kilo per day, and they were getting a cyclic PN. So they made sure, which is important also, they drew the fatty acid panels after the lipid was off for 6 hours. Obviously, you don't want to draw with the lipid because that's not going to be accurate, and you need time for the lipid to clear in order for it to get this accurate fatty acid panels. And so what they really found was that these fatty acid profiles really reflected the composition of the 4-oil lipid emulsion they were getting. The patients had increased EPA and DHA, they had decreased ARA and meat acid. They were getting a lot, this particular ILE has fish oil in it, so you would expect to see increased EPA and DHA levels. The Holman ratio was unchanged, so they didn't have any changes in their TT ratios during this long-term PN period. And then they actually observed a decrease in meat acid and ARA over time, and most importantly, all of these pediatric patients had normal growth. So I think it illustrates when lipids are dosed appropriately, you see growth, especially in your pediatric patients, appropriate growth, and you don't see EFAD. So again, it all goes back to we need to dose the right way. So when we look at 100% fish oil, so this is indicated just for pediatrics, so usually that's when you see it, and the prevention of EFAD. It kind of brings up this question of what truly is essential for the fatty acids. Is it the parent EFAs of LA and ALA, or is it those downstream products of DHA and ARA? It's kind of a debate. Then there's this idea that the downstream products can kind of retro back to those parent products, which is why we will see a lot of times with 100% fish oil that patients have normal LA and ALA levels, even though they're not really getting it in the actual fish oil. So they looked, most of the 100% fish oil studies were done at Boston Children's and Texas Children's, and then they used UCLA as kind of their control group for historic data. And so there have been case reports of higher doses of fish oil ILE needed for adequate growth and prevention of EFAD, but usually what they've seen is they can prevent EFAD and in some cases even reverse it. The first compassionate use for 100% fish oil was done at Boston Children's on a patient that had been unable to have ILE because they had a soybean allergy, and that was all that was available, was 100% soybean oil, and they had developed EFAD, so they brought in 100% fish oil on compassionate use and gave it to this patient, and they were actually able to reverse that patient's essential fatty acid deficiency. So that's kind of where this idea of what is truly essential kind of comes from. And so you can see in this study that when looking at 100% fish oil ILE, there were no clinical signs of EFAD reported in the cohort from Boston Children's, no signs of biochemical EFAD or a TT ratio greater than 0.2, long-term in the patients for up to over 200 weeks. And one patient had been on it for almost 8 years and with no sign of a deficiency. So when we look at fatty acid profiles in pediatrics, this study looked at patients that were anywhere from 2 weeks old to 18 years. They're on long-term PN, and they were given 100% fish oil ILE at 1 gram per kilo per day for 6 months, and then they evaluated these fatty acid profiles at baseline, 3 months, and 6 months. They found no physical manifestations of EFAD, so there were no clinical symptoms, no evidence of biochemical EFAD while on 100% fish oil, and the TT ratios were unchanged and normal compared to the age-specific ranges, and the meat acid decreased over time, which is what we saw in some of those other studies. So fatty acid monitoring, when do we do it? What does the PI say? So looking at the different prescribing information for the IV lipid emulsions that are available, not a lot of information. 100% soybean oil doesn't really say anything in their PI, most likely because it is indicated for the treatment of essential fatty acid deficiency, so they don't really give any monitoring for that since it's used to treat it. But with the alternative ILEs, you can see that the monitoring per the PI is pretty much the same. They just say to monitor it. And a TT ratio may not be adequate to diagnose EFAD. And, so assessment of the individual fatty acid levels may be needed. So for the 4-oil emulsion, at least that's recommended, which is what we've talked about, that you can't just look at one thing. You have to look at the individual fatty acids too. But still, none of the PIs give any type of frequency or direction on how often do we monitor these. So Dr. Gura did, out of Boston Children's, in one of her papers, she did kind of talk about it in her study that was in NCP in 2019, but she really says to just monitor it at baseline and really only check it if they have signs and symptoms of EFAD. This was because it's Boston Children's, it was 100% fish oil, but if they're receiving a lower dose than what's recommended, dose minimization, or they've been exposed to a previous ILE that was minimized in dose. But other than that, there's really not any recommendations out there. It really is clinical judgment as to when you're going to check these. There's the thought that, do we really need to check them? If we're dosing appropriately, we're not seeing any signs and symptoms, do we need to really check them? Maybe, maybe not. And then that's just what was in the prescribing information, same as the previous slide. So bottom line, monitoring for fatty acid status in PN patients, it's really important to look at the whole patient. We really want to assess their weight gain, how are they growing, what is their skin and hair, all of those clinical manifestations we might see. And when do we consider obtaining a fatty acid profile? Really, if we're seeing any type of physical signs of deficiency, if we're seeing any of these skin manifestations, if we have a pediatric patient that's not growing and maybe has stalled on the growth curve, maybe that's a time to check it. If the patient's severely malnourished, if we're minimizing ILE dose, if they've been, for some reason, their ILE's been held, especially for a long period of time, over 2 weeks, that's when we really want to check these. And it's important to check with your manufacturers of the ILE products and professional organizations out there for what do they recommend for dosing and monitoring. Underdosing, as we know, because I think I've talked about it through this whole thing, underdosing is what will lead to EFAD. So it's really important that we're appropriately dosing our patients so that we prevent deficiency. And then review the fatty acid profile results in the context of everything. Their nutrition history, what dose are they getting? Again, clinical signs and symptoms. Evaluate all the levels, not just the TT ratio. You really need to look at that meat acid, LA, ALA, and see what's going on with the whole patient. It's really important to treat the patient, not just the numbers. We don't want to be just chasing a number like, oh, everything looks okay, but their LA is low. Let's give them this because we got to get it up. That's just number chasing. We really need to look at the whole picture. So in summary, laboratory reports for fatty acid reference ranges really reflect the population norms that were studied to get those reference ranges. They're not representative of optimal levels, nor really are they representative of diagnosis of deficiency. Fatty acid profiles really reflect the composition of what they're receiving, whether it's oral, PN, EN. We really are what we eat. And that's what your fatty acid profile is going to look like. The Holman index is the diagnostic threshold for biochemical EFAD. It's the gold standard. It really is what needs to be used when you're looking at those fatty acid panels. And again, refer to manufacturers and professional organizations. If you're seeking guidance, whether it's for dosing, for anything that you need recommendation-wise, it's really important to reach out to those people to do that. And then we will skip through these because we don't have to do them for this. And I will take questions if anybody has them. Thank you.